Okay, so yeah, I've tried to concentrate on things that I think could come up in your exam. I don't set your exam, so I don't know what the question is, but I've seen lots of examples of previous exam questions. And today I'm going to talk about anemia, and mostly about anemia, actually. So where are we for this? Oh, here we are. Mostly about anemia. There's just a little bit about thrombocytopenia at the end. Not heaps. And then next week, I'm going to be talking about bleeding, clotting, and anticoagulants. So that's what we're in for. And this is all going to be case-based, which tends to be how your exam gets set, I think. It certainly is how your mock exam was. It's like a bit of clinical information, a bit of some haematology laboratory results, and then usually the question goes along the lines of which of these do you think is the most likely diagnosis, which is admittedly a little bit of an artificial situation. In real life, you have more information and you wouldn't come to a diagnosis on that, on just what you're given in the question. But I think it still does test your knowledge, and you should be able to work out the answers if you've got enough background knowledge. So, I saw in your mock exam I don't think they gave you reference ranges, did they? No. Was that a problem for answering the questions? Yeah. Was that a big part of the problem? Yeah. Because I can feed that back to Diane, because I mean, it's good to learn the reference ranges for the blood counts, just because have a rough idea of what normal is, but in real life, you will always have the reference range for your laboratory and your population. They're generally similar around the world, but there'll be subtle differences, hospital to hospital, country to country. But your laboratory, when you're actually working as a doctor, will give you a reference range, so you can always check, is this normal or isn't it? But in the hope of sort of getting these figures into your head, just in case they don't give you, I think they ought to give you reference ranges for exam, but just in case they don't, here are the adult reference ranges for red cell parameters. And they're actually not that hard to remember. So hemoglobin male is 130 to 175, female 115 to 155. And then the mean cell volume, which is red cell size or average red cell size, 80 to 99, it's usually 80 to 100-ish. MCH, mean corpuscular hemoglobin, so that's how much hemoglobin there is. Average hemoglobin content of the red cells, 27 to 33. Reticulocytes, everyone remember what reticulocytes are? Early red cells, they've lost the nucleus, but they've still got a lot of RNA in the cytoplasm. And if we stain them with a supravital stain, we can see that RNA. So it's like a network of RNA, so it's called reticulocytes. And they're a reflection of how hard the bone marrow is working to replenish red cells. And that's a really important, useful measure. And we measure that in two ways, either an absolute count, 10 to 100 or by 10 to the 9 per liter, or a percentage of the red cells. And up to 2% is generally normal. So I hope that I think I've committed these to memory, and I hope so I can remind you as we go through. And just bear in mind that small children are different. So neonates have a polycythemic, and infants have got lower hemoglobins. So, and pregnant ladies in late pregnancy, it's normal to have a slightly low hemoglobin of around 100. Okay, so whenever you've got a case that involves anemia, if we boil it down to real simple principles, one of the things to think about, is it just a red cell problem, or is the problem affecting white cells and platelets? And then there are two ways of looking at analyzing anemia logically. The one that we use most of the time is the red cell size, so MCV. So it is worth looking at MCV. I think a lot of qualified doctors, by the time they get to be qualified for a few years, they've forgotten what MCV is, and which means that they find it hard to interpret anemias. Mean cell volume, size of the red cells. And then the other feature that's really quite useful in some anemias is the reticulocyte response. How is the bone marrow responding to the anemia? Is it able to produce more young red cells, or is it just not responding for some reason? Has it not got the ingredients it needs to make the red cells, or is it infiltrated with something that's stopping the normal bone marrow work? So those are kind of general principles. And this is the morphology. So you've got low, normal, or high MCV, small, normal, large. And the other one is the reticulocyte count. So if there's a reduced red cell, what is the pathology underlying? What's the kind of pathology process? So is it that the bone marrow is not functioning? Is it that there's red cell loss and the bone marrow is working overtime to counteract that? Or is it just that there's a big spleen and there's dilution? In which case the retics would probably be normal. So onto the cases. So the first one, I've been very unimaginative and called them by letters of the alphabet. Mrs. A, who's 63. So and she's been tired for about 6 months. She's had a change in bowel habit. She's got recent diarrhea and weight loss. So already you've probably got a couple of things in mind. And not surprisingly, she looks pale because her hemoglobin's only 89. Normal for a woman being 115 to 155. And her MCV, normal MCV, we said was around 80 to 100, 80 to 99 in my hospital. So she's got a low MCV. She's microcytic anemia. The white cell count is normal, but the monocytes are in fact slightly high. The upper limit of the monocyte reference range is 1.0 usually. So she's got a bit of a monocytosis, and she's got a slightly high platelet count. Normal platelet count is 150 to 400. So as we go along, I don't mind if you guys want to shout out. My experience of doing interactive stuff with Zoom and in-person stuff has not always worked well. But if you want to shout out or interact, I'm happy, or put questions to me, I'm happy to do that. But in your own heads, at least, you should be trying to think what are the possible diagnoses? What's your differential? Yeah, platelets go up in platelets are, if you like, sort of acute phase cells, like ferritin and CRP are sort of acute phase proteins. Platelets, you can look at them as acute phase cells in a way. They go up as a reactive phenomenon to almost anything that causes inflammation. So, yeah, infection, inflammation, bleeding, trauma, surgery. Pretty much anything that causes some kind of inflammation will put the platelets up. And the differential with a high platelet count is it reactive, or is it a hematological malignancy? Is it a myeloproliferative disorder? But yeah, platelets go up in infection, absolutely. And monocytes, the monocytes are quite useful. High monocyte count is quite useful because there's only really three groups of conditions that cause a high monocyte count. One is malignancy. One is chronic infection like TB. And the other one is hematological condition, a myelodysplastic or technically myelodysplastic stroke myeloproliferative disorder called chronic myelomonocytic leukemia. So again, with white cells, it's also similar. White cells can go up as a reactive phenomenon, or they can go up as part of a hematological tumor involving the white cells. So we've got this lady, change in bowel habit and weight loss. You've got to think about cancer, bowel cancer, haven't you? or GI cancer. But I guess you could think it might be a chronic inflammatory process, or potentially even a sort of gut TB or something. So you can't tell for sure so far. But if we're thinking about what kind of anemia is this, if it was a chronic inflammatory process, you might be saying, is it a chronic anemia of chronic disease? It could be, except that the hemoglobin's a bit low. Anemia of chronic disease generally isn't less than 95. So already, as a hematologist, I'm thinking this is probably iron deficiency due to malignancy. I can't exclude a chronic inflammatory, chronic infection processing, or even inflammatory bowel disease possibly, but it's a funny age to develop inflammatory bowel disease. So just to refresh, and I think it's well worth putting a bit of time into learning these lists. There's three lists really, one for microcytic anemia, one for macrocytic anemia, and one for normochromic normocytic anemia, just because if you get an anemia case, it's going to be one of those, and it will help work out what's going on. So yeah, I think it could be iron deficiency, hyperchromic microcytic anemia, could be chronic disease, but I think the hemoglobin's a bit low. Thalassemia, the indices I've given you, it could be a thalassemia trait, but actually usually thalassemia indices are lower than, the MCV is lower. And this is all quite subtle, so I don't think you'd be expected to know the answer from what I've given you so far. But it probably isn't thalassemia, just because for that hemoglobin, the MCV would be a lot lower. Lead poisoning causes hyperchromic microcytic anemia. It causes constipation rather than diarrhea. Some sideroblastic anemias. Sideroblastic anemias are a bit small print. There's really small print congenital forms. There's acquired forms due to sort of alcohol excess, there's some drugs, and then some myelodysplastic disorders. But none of those seem to really fit very well with her picture. Yeah. Sorry? What are they caused by? There's multiple different causes. Some are genetic, so inherited genetic disorders, and there are several of them. Some are caused by exposure. So you can get exposure to huge amounts of alcohol, pyridoxine deficiency, and then myelodysplastic disorders. So that's like a sort of pre-neoplastic hematological disorder, which I think you will have been talked about, the sort of pre-AML clonal hematological stem cell disorder. So lots of different things. Yeah, three groups of things anyway. But yeah, I'm just wanting you to sort of think through what are the possible causes of microcytic anemia, which of those could be, could fit with this case. So if I give you a bit more information, it might make it easier. And you would need more information, I think, to be able to come to select one of those items. So I'm saying there's hyperchromic microcytic red cells, which you already think probably is going to be the case because the MCV was low. But I'm also saying pencil cells and a few target cells. And I think you do have to learn some of these things, some of these really frequent blood film comment, or the blood film comments that happen in common anemias, because that seems to be the way the questions get phrased. You're not expected to interpret the blood film, but I'm just giving you the blood film so that you can see what I'm talking about. So the pencil cells are these long, elongated, sort of look like cylinder type things. And then the targets, normal red cells have got like the middle third is pale, and then the rest of it, the other two-thirds, the third either side of the central pallor is full of hemoglobins, but these are quite small and pale. The central pallor is too big. And then there's some that look like artery targets called target cells. And I think the thing that makes me think it's iron deficiency is the pencil cell. All the rest fits, but the pencil cell makes me think it's iron deficiency. And another clue might be, hopefully we would give you more than one clue. I don't know if anyone remembers what RDW is, red cell distribution width. it's a measure of the variation of red cell size. So there's quite a bit of, if the RDW is high, the red cells vary quite a lot in size. And this is high at 20%, and that's another feature of iron deficiency, and it helps to distinguish iron deficiency from thalassemia. So, and another way of describing that from the morphology is saying anisocytosis, but again, it just means variation in red cell size. So I think this is iron deficiency. Do you want to go back to the, I don't know if you want to go back to the case. I think it's iron deficiency rather than chronic disease because the hemoglobin is too low for chronic disease. I think the blood film findings are characteristic of iron deficiency. In real life, you would do a serum ferritin and try and find, confirm your suspicions. But generally, the questions ask you to come up with, there's a list of options and they ask you to come up which do you think is the most likely. Are there any questions on that one? Yeah. You're right. Yeah, no, you're absolutely right. And anemia in people who are alcoholic or drinking huge amounts of alcohol is multifactorial. The classic effect of alcohol and of alcoholic liver disease is macrocytic anemia. You're absolutely right. Both of those, macrocytic anemia. But very, very large quantities of alcohol can sometimes give you a sideroblastic picture. And it might be that that's multifactorial too. It may be that maybe it actually isn't the alcohol. Maybe it's the vitamin deficiencies associated with, in the diet of someone that does drink huge amounts of alcohol. That's quite possible. TB drugs, isoniazid, I think, gives you sideroblastic anemias as well. But no, you're absolutely right. The classic anemias with alcohol and with liver disease are macrocytic. You're right. Yep. Yep.
You mentioned with the people cell
Yep.
would you get like the target cells of other blood cells
Yes. Yes. Yep. You do. I might go on to that in a minute. Yeah, target cells. I have got a slide on that, which is why I'm hesitating slightly. But yes, you're absolutely right. Thalassemia, you would expect to see lots of target cells. Some of the other hemoglobinopathies, you can get target cells. Hyposplenism, you'd get target cells. And you also get target cells in liver disease, but as you quite correctly said, liver disease usually gives you macrocytic anemia. So macrocytic anemia and target cells make you think liver. Microcytic anemia with lots of target cells probably should make you think hemoglobinopathy, but you can get some target cells in iron deficiency. RDW is classically high in iron deficiency and classically normal in thalassemia. There's less variation in red cell size in thalassemia, whereas the iron deficiency, you often get lots of variation in red cell size. Okay. So we've done that. So this is Mrs. B, not Mrs. A. She's also aged 63 years. She's also been tired for 6 months, but this time we know she's got rheumatoid arthritis. This is going to be really easy for you. So she's had a recent flare of joint symptoms, looks a bit pale, and she's got joint deformities consistent with rheumatoid. She might even have rheumatoid nodules, who knows. So her hemoglobin is low, but not as low as the previous lady. She's got a low MCV because we said 80 to 99 was normal. She's got slight neutrophilia because generally it's sort of 2.5 to 7.5, and the white cell count is slightly high, normal being 4 to 11. And her platelets are slightly high, which, as we said, could be a reactive change. And her CRP is a bit high. So you probably know what the most likely diagnosis here is. Do anyone want to hazard a guess, or shall I just? I mean, I can't exclude that it's iron deficiency. I can't absolutely excluded isn't any of those causes of microcytic anemia, I guess. But in the context of her clinical features and the high CRP and what's probably a reactive neutrophilia and thrombocytosis, chronic disease, somebody say chronic disease, is the most likely. And I think the exam situation is artificial, but I think it's about you learning to create a sort of differential. What would be first on your differential diagnosis? What is the most likely thing? So this is another lady with anemia, a little bit younger, 28. She hasn't got any symptoms. Her hemoglobin's about the same as the last lady, but she isn't feeling tired. She feels normal. And that might give you the idea that she's had it for a while, because you tend to, people who have a recent anemia tend to be more symptomatic than people who've had an anemia for a long time. She's of Indian heritage, which may or may not be relevant, and she's planning a pregnancy. So that might focus the doctor's mind on things that could be a problem in pregnancy. So she's got a microcytic anemia, but her MCV is really low, 80 to 99 being normal, 62 is really low, and her MCH, mean corpuscular hemoglobin, is really low too. I think we said 27 to 33 was normal. Her white cells and platelets are normal. And again, you can't make a diagnosis on that, but you could have you might suspect something. And no doubt things are going through your heads. And just to refresh and to do some repetition, these are the main causes of microcytic anemia. Yeah, it could be iron deficiency, but the MCV is really low. Could be chronic disease, but the MCV is really low. Thalassemia it's got to be something you've got to think about, because she's of Indian heritage and she wants to be pregnant. Lead poisoning, possible. I think the last case of lead poisoning in New Zealand that I know about was it was lead in Ayurvedic medicines. But again, the MCV is really low. And same for sideroblastic anemias. Yes, it could be, but the MCV is very low. But again, I don't think you have to diagnose on the blood count alone. I think you'd be given more information. And the blood film shows frequent target cells. And we said frequent target cells, microcytic anemia, likely to be a hemoglobinopathy. Occasional basophilic stippling. Basophilic stippling is of use in diagnosing anemias, but there's only the occasional one, and it really just tells you there's a bit of dyserythropoiesis going on, which can happen in dysplastic syndromes, myelodysplastic syndromes, but can also occur in small amounts in other anemias. And I'll show you a picture of that in a minute. And I think we'd also, in your exam, I think we wouldn't, maybe a consultant hematologist or an advanced trainee in hematology should be suspecting this from the blood count. The medical registrars should already have made the diagnosis, but for you, I think we'd need to give you this information to expect you to come up with a likely diagnosis. So we've given you the fact that ferritin is normal, so it doesn't look like iron deficiency. I guess we don't know that she's got any inflammatory conditions to raise the ferritin from as a acute reactive change. Sometimes people who are iron deficient can have ferritins in the low normal range because they've also got an inflammatory process, but we don't have any reason to think she does. And then we've got some hemoglobinopathy studies. So she doesn't have any abnormal hemoglobin peaks. So by that they mean she hasn't got hemoglobin S, she hasn't got hemoglobin C. So it's not sickle cell, but she does have high hemoglobin A2 at 5.2%. And she doesn't have H bodies. If we think back to what hemoglobin A, hemoglobin A2, hemoglobin F are, hemoglobin A is alpha 2 beta 2, A2 is alpha 2 delta 2, and F is alpha 2 gamma 2 in terms of globin chain composition. So what happens when you're I mean, the fact that there's an abnormal distribution of the hemoglobins is, I guess we're looking for a hemoglobinopathy. We haven't found we haven't found an abnormal peak, so we must be thinking thalassemia. So we've then got to decide which type of thalassemia. So if thalassemia is named after the globin chain that's missing or reduced. So if it's alpha thalassemia, there's too few alpha chains causing an imbalance. If it's beta thalassemia, it's the beta chains that are too low. And if beta chains are too low, you won't make hemoglobin A properly, or won't make a full amount of hemoglobin A, but you will be able to make delta and gamma chains. And often what happens is you compensate by making more of it, one or other of those two. So I hope that made some sense. This picture, this hemoglobinopathy screen, already with the raised A2 and a normal or a raised hemoglobin F is suggesting a beta thalassemia tray. And the H bodies, I don't know if you remember what H bodies are, but they are beta globin, sort of beta 4. So 4 beta globin chains all together. So that's an H body. So if you can't make enough beta chains, then you're not going to be making H bodies. That's something that happens when you're not making enough alpha chains. I hope that makes sense. Thalassemia is actually logical. Once you've understood that there's what the components of hemoglobin A, hemoglobin A2, and hemoglobin F is, and once you've understood there are 2 beta globin chain genes, and there are 4 alpha globin chain genes. But this is a picture of beta thalassemia tray. Is it as clear as mud, is it? By the looks on everyone's faces. It is, I think you are supposed to know about thalassemia and sickle cell at least. Maybe not all, not the small print hemoglobinopathies, but I think thalassemia and sickle cell, and at least what the typical findings are. And it is logical, it can be worked out. So I think she's got, yeah, I think this is compatible with beta thalassemia tray. So it would be a problem if, with her becoming pregnant, but only if her partner is carrying something that combines with beta thalassemia tray to cause a serious hemoglobinopathy, and that is either beta thalassemia, in which case they've got a 1 in 4 chance of having a child with beta thalassemia major, a severe transfusion-dependent anemia, or if her partner is carrying sickle hemoglobin S, because S beta thal is a sickling disorder. It's sickle cell disease, one of the forms of sickle cell disease. Anyway, so we've done, what have we done? We've done iron deficiency, we've done chronic disease and thalassemia, hopefully. How would the picture look different? Normal. And you might, depending on how many alpha thalassemia generally is gene deletions, and beta thalassemia generally is point mutations. And there are 4 alpha genes, 2 from each parent. So generally for alpha thalassemia tray, you've got 1 or 2 gene deletions. 3 gene deletions is hemoglobin H disease, which is a sort of thalassemia intermediate. So it's generally hemoglobin 80 to 90 with splenomegaly, but largely asymptomatic until at least middle or late life, when they do get some of the complications of major thalassemias. But where was I going with all that? Yeah, so if you've got a 1 gene deletion, you might just, everything might be normal. If it's a 2 gene deletion, you might see some H bodies, which are those beta 4 deposits. And if it was a 3 gene deletion, a hemoglobin H disease, then the patient would be anemic and you definitely see H bodies. That make sense? Yep. So in terms of diagnosing thalassemia, chances are it'll be a thalassemia tray they give you. I don't think you're expected to diagnose hemoglobin H disease, but so you only really have to know about what alpha thal tray and beta thal tray look like, and alpha thal tray can look completely normal. So it's like it's a hyperchromic microcytic anemia, usually very microcytic, normal iron, no reason to think it's chronic disease, normal hemoglobinopathy, it's green, and the comment usually comes back, can't exclude alpha thalassemia tray. And if you really want to know, you have to do genetic studies. So we talked a bit about basophilic stippling in passing in relation to thalassemia, because there is a bit of dyserythropoiesis in thalassemia. But if you see lots of basophilic stippling, then that's either lead poisoning or one of the sideroblastic anemias, usually include, the most common of which would be myelodysplasia. Clonal hemopoietic stem cell disorder that often develops into AML. So it's just another clue on the blood film report. If you know what causes basophilic stippling, you've got another piece of information to put in the jigsaw. Target cells we talked a bit about. So yeah, target cells are quite useful. If there's lots of them, it's likely to be, and it's a microcytic anemia, it's likely to be a hemoglobinopathy, either a thalassemia or a hemoglobin C is one that has a lot. Or if there's just a few, it might be iron deficiency. And if it's macrocytic and lots of target cells, likelihood is it's liver disease. And the other big diagnosis to bear in mind with target cells is hyposplenism or splenectomy, in which case you should see other features, including Howell Jolly bodies. I'll show you a picture of that later. I hope it's not too technical. You don't have to be hematologist. You don't have to interpret blood films. Chances are you'll get 2 or 3 bits of information that are likely to lead you to the answer. But the things that I'm talking about today, if you can get those into your head, it will give you a real good head start to both doing the exam and practicing and being a practicing doctor. So I think that's probably enough on microcytic anemias. I haven't shown you a case on sideroblastic anemia. We could, but I haven't. So this is a bit different. Still a young lady, tired. They're all tired because it's anemia. Dyspnea on exertion. She's been vegan for 10 years. I mean, it might be relevant, it might not. It probably is if they tell you in the exam, but she's not on any medication and she's very mildly jaundiced. So she's pretty anemic. It's not surprising she's tired. She's got a really high MCV. So if it's 80 to 100 is normal, then 116 is really high. And she's also got, it's not just the red cells. Early on I said, look, is it the red cells alone or is it red cells and other stuff? Her neutrophils are a bit low because the low limit of normal is 2.5. And that's why the white cell count is low. And the platelets are also a bit low because normal is a 150 to 400. So does anyone, I mean, again, what I'm hoping is going through your head, especially the 5th years, is what are the causes of macrocytic anemia? So that, and then you can think which of those is the most likely. The thing about being vegan is that it's only, in terms of dietary B12 deficiency, it's only really strict vegans who get dietary B12 deficiency. Obviously, there are other causes of B12 deficiency, but if you're thinking about dietary B12, vegans. But vegans can get other stuff too. And the reticulocytes, I said reticulocytes are important. And I also said, I think the normal was 10 to 100 by 10 to the 9th liter or up to 2%. So she hasn't got much, she's really anemic, but her bone marrow is not making red cells. It's not responding like it should. It should be really high because she's anemic. So bone marrow should be making heaps of red cells. It's not. So that was, I was hoping those things were on your list. B12 or folate deficiency is vegan. Liver disease, I mean, I can't exclude it, but we've got no reason to think that. Myelodysplasia, she's pretty young for myelodysplasia. Anyone can get myelodysplasia, but usually it's a disease of the elderly, older person. Elderly's about 10 years old, or isn't middle age 10 years older than you are, so that's, anyway. Alcohol, you correctly said alcohol causes macrocytic anemia. Drugs, and I really mean medication drugs, not recreational drugs. So things like cytotoxic drugs, some of the HIV drugs will give you macrocytosis, and I think some of the anti-epileptics as well. And myeloma, I put myeloma in there. Actually, somebody's going to tell me, well, myeloma normally causes normochromic normocytic anemia, and you'd be right, it does normally cause normochromic normocytic anemia, but sometimes it causes macrocytic anemia, so don't be put off if the MCV is high. So all of those things have to be considered. But one really useful bit of information about the MCV here is that it's pretty unusual for somebody with an MCV of more than 115 not to have megaloblastic anemia. And the classic cause of megaloblastic anemia is either B12 or folate. It can be due to medications, but generally, you know, if the MCV is more than 115, think B12 folate first off. And she is vegan, so she could be. Easy, really. So her blood film showed oval macrocytes, which is, I'm afraid it's just something you have to learn, really. You can try and explain it. You can say, well, the B12 is needed for DNA formation, and it doesn't divide properly, and so you get big cells. Maybe that's what happens. But oval macrocytes are classic of B12 folate deficiency. And the other thing that's classic is not exclusive to B12 folate deficiency, but is absolutely classic of it, is hypersegmented neutrophils. So if you see those things written on the blood film report, think B12 folate. Hypersegmented neutrophils, neutrophils should have somewhere between 3 and 5 lobes, but this one's got, heaps, 1, 2, 3, 4, 5, 6, 7, probably 8, at least 6, maybe 8. Lobes, so too many. And again, you won't be given blood films to interpret it, but I'm just trying to bring it to life a bit by giving you the picture and explaining what it is we're talking about. You'll get the words. So I think she's probably got B12 deficiency, but we would want to measure the folate as well. That makes sense? And it's probably the first thing you should think about. If you get a macrocytic anemia, you probably should think of that first, even if it's just to exclude it. It's easy to test, exclude it, think again. But if you get these words written on the blood film report, then you've got to be thinking B12 folate. So we're down to Mr. E, who is 73. Surprisingly, he's also tired and also has a macrocytic anemia. So his hemoglobin is 60 as well, but his MCV is not quite as high, 108. And he's quite a bit older as well. Different age group, different likely pathologies. He's got worsening angina, presumably because he's anemic. If he's got ischemic heart disease and his hemoglobin's dropping, that's why presumably he's getting worsening angina. He's also getting skin infections. Even though his neutrophil count's a bit low, but it's not really low enough to give somebody increased infections. So that, to me, as a hematologist, suggests there's something wrong with either the neutrophil function, particularly if it's bacterial infections, or some other part of the immune system. But I'm suspicious there could be a functional problem with his neutrophils, because he's got enough, not normal amounts, but enough to protect him from bacterial infections, but he's still getting them. And he's got a bit of a thrombocytopenia too. So there's some kind of And his reticulocyte count is low as well, so the bone marrow is not responding to the anemia. So again, we have to think about all the same things that we thought about before: B12 folate. What else did we think of? Liver disease, alcohol, drugs, myelodysplasia. I think, what did I miss out? Something. Oh, myeloma, possibly. Having emphasized that to you, I then go and forget it. Myeloma. So you can't tell from here. I mean, there's something, the bone marrow is either missing ingredients like B12 or folate, or it's infiltrated with something that's replacing the normal marrow, or it's being suppressed by medication. So there's got to be some reason, and it's really one of those three things why the bone marrow is not responding. So we do get a bit more information, and you would need more information. Even the most experienced hematologist would need more information. So you're getting told there are pseudo-Pelga cells, and there's variation in red cell size, but that happens a lot. So I don't know if you remember what pseudo-Pelga cells tells you. It's another word that's worth learning about. It's worth learning these things because they tell you what's going on. Some of the blood film comments don't tell you much, like anisocytosis, or what the red cells vary a bit. But pseudo-Pelga cells is a fairly specific thing, and that's what a pseudo-Pelga cell, and apparently, or sometimes known as pseudo-Pelga Hewitt, and it is Hewitt because he was Dutch, apparently, not Huey, which is what many people say. So it's an abnormal looking neutrophil. So I said before, neutrophils have 3 to 5 lobes. This one hasn't got enough, it's only got 2. And the other thing that's abnormal about it is there are no granules in the cytoplasm. Neutrophils are granulocytes, they should have granules. And they don't, this one doesn't. So it's abnormal looking. And it's very characteristic. There's also, the red cells are a bit varying in size, and there's a slightly funny looking platelet on the right, a bit big and a bit odd. And I don't know, the red cells are not too bad, but a little bit, there's a teardrop in the corner. I don't know if I can point to it. There's a teardrop poikilocyte in the corner. But the big abnormality is this Pelga Hewitt cell, and that's characteristic of myelodysplasia. So this guy, that's the next patient, sorry. This guy here, he's got a macrocytic anemia. It's actually a pancytopenia with a severe macrocytic anemia. His neutrophils probably aren't functioning because they're not normal. They don't look normal and they don't function normal. And he's got a characteristic feature of myelodysplasia. And he's in the right age group. It all kind of fits. In practice, we'd do a bone marrow, we'd do cytogenetics, but that, if you're thinking, what is my number one diagnosis? What is my on the differential? What is the most likely thing I would go for myelodysplasia if you have a list of things? And usually you get given a list of things like, it'll include myelodysplasia, but it'll also include Hodgkin's disease or CLL or acute leukemia or something. So mostly you can exclude some of the other things on being ridiculous, but this one is possible and likely. So, still doing macrocytic anemia. This person is, I'm not going to talk lots about platelets, you're right, we're not going to be here all day. Mr. F is 49. He is long-term homeless, comes in with confusion, bit pale, tired, jaundiced, has a big spleen and multiple spider nevi. You do have to remember your general medicine when you do the exam as well, because what does spider nevi mean? And it should make you think about liver disease, cirrhosis. So he's got a macrocytic anemia, reticulocytes. It's actually normal, but they should really be a bit high because he's anemic. But they're not too bad, nowhere near as bad as the other guys. He's got normal neutrophil count and low platelets, but he's got splenomegaly. So people with splenomegaly generally do have low platelets, so that might be why. And then on the blood film, there are macrocytes and multiple target cells, and you guys will all know instantaneously that it's liver disease. And there's a picture of the target cells, lots of them. And I'm a bit suspicious it might be alcohol, but I can't prove that to you. And I also can't prove to you that he's got cirrhosis, but that's my suspicion on the basis of this, the information that we've got, and it'd be much more likely than CLL or Waldenstrom's or aplasia. I mean, he could have aplasia, but probably not. The target cells doesn't fit. He hasn't got hemophilia, as far as I know. No reason to think he's got hemophilia as well as everything else. So if you get a list of things, some of them you'll be able to rule out. It's unlikely to be, he might have iron deficiency, but what we're looking at here is not primarily iron deficiency because it's a macrocytic anemia. Hope I'm not confusing you too much. I'm just thinking through what sort of lists you might get. Oh yeah, here we are, sorry. I've stolen my own thunder. So I've got two lists here because it was a really long list and you wouldn't be able to read it because it would have been too small. But here's half of the list. Which of these is the most likely diagnosis? Well, it could be hemolytic anemia. There's no reason why it couldn't be. You can have if you have a lot of reticulocytes are big cells. So if you have a lot of reticulocytes in a bone marrow response to a really brisk hemolysis, you can get a macrocytosis from that. Could be. Iron deficiency, well, he could have iron deficiency. He may well have concurrent iron deficiency, but the picture we're looking at is not typical of iron deficiency. This lead poisoning is a microcytic anemia, thalassemia is a microcytic anemia, and this is macrocytic. Liver disease, I think, is got to be number one because he's got his clinical features, his macrocytic anemia, and the target cells. I think it all adds up to most likely being liver disease. B12 deficiency definitely causes macrocytic anemia. It could cause thrombocytopenia, but it doesn't really fit that well with his clinical features and his target cells. So you probably, in practice, you probably would check the iron and the B12 and folate, but your suspicion would be the primary problem is liver disease. And I think that's what people are getting at in these kind of questions. It doesn't, I mean, again, acute leukemia, you can present with cytopenias. It generally doesn't present with macrocytosis unless it's arising out of myelodysplasia. We've not seen any blasts. We've got no reason to think it's that. Aplastic anemia, again, possible, but not the most likely thing. Not as, he's presenting as someone with liver disease. Aplastic anemia is rare. Anemia of chronic disease, probably not, because that's usually normochromic or normocytic or microcytic. It's not CML, chronic myeloid leukemia, chronic granulocytic leukemia, because that causes neutrophilia. It's not CLL, because, well, it probably isn't CLL because there aren't enough white cells left to cause CLL to be excessive lymphocytosis. Myelofibrosis, I don't know if you remember what myelofibrosis being one of the myeloproliferative neoplasms where the bone marrow fills up with fibrous tissue and you end up with hematopoiesis occurring in enlarged liver and spleen. And the classic picture is a pancytopenia with those funny teardrop poikilocytes and early red cells and white cells in the blood, leukoerythroblastic anemia. So it's not that, because that's not what we saw in the peripheral blood. So I think sometimes it's hard to be you can't absolutely exclude things, but you can choose something that's likely. So I just wanted to show you leukoerythroblastic film just because that's another word that is worth learning and understanding because it tells you a lot about what's going on. So leukoerythroblastic just means in the peripheral blood there are early granulocytic cells, there are early red cells, nucleated red cells, neither of which should be there. And that tells you that the bone marrow is either very stressed or it's infiltrated with something. And one of which is myelofibrosis. It could be cancer, or it could be just, severe hemolysis, severe bleeding can give you leukoerythroblastic changes. So yeah, that's what I think. I hope it's not too, I hope it does make sense. I mean, like exam questions, I think you generally can work out what's going on. If you've got the basic information, you'll be able to, you'll come up with what's most likely. And in some ways it does reflect normal life, that normal life is it's not necessarily absolutely cut and dried. You don't necessarily get the stereotypical presentation. So macrocytic anemia just is to hammer home the point that I think it's good to learn the list because I think it will help you interpret your exam questions. And then we've done microcytic and macrocytic anemias, so we've got to talk about normocytic anemias. So normocytic just means normal MCV, and bear in mind that MCV is an average figure, so sometimes they'll all be normal size, sometimes you'll get a mixture of small and big cells. This is Mr. G, who's 80, our oldest patient yet. He's really anemic, but the MCV is normal. He's got pretty much normal white cells, slight neutrophilia, slightly high platelet count. He's been on non-steroidal he's been on Voltaren for ages for his arthritis. And he's suddenly collapsed with abdominal pain, hypotension, and offensive dark black diarrhea. So, I mean, if he's presented with collapse and melena, you've already got the diagnosis, really. I guess I didn't tell you on the slide that he's got melena, but he has. And he's at risk for melena because he's on non-steroidal anti-inflammatories. So you probably know what's going on. His red cells look normal. Here's some pictures of normal red cells. And there's a list for normochromic normocytic anemia too. And if you have a quick, chronic disease can be either microcytic or normocytic. Marrow infiltration, marrow failure, hemolysis, early iron deficiency, but acute blood loss has got to be on the cards, I think, for this person, just on clinical grounds, really. If he's just had the bleed, if he was fine and then he's just developed a bleed, the marrow might not have time to produce the reticulocytosis, but the next day there'll be a reticulocytosis. So you may or may not see a reticulocytosis, but if you do, that's the marrow responding to an acute anemia due to acute bleeding. Okay, we're getting there. We are getting there. This is a 65-year-old man, tired, back pain. And quite a lot of 65-year-old people are tired with back pain because there are lots of common conditions that cause back pain. But some back pains are quite serious, and it is easy to overlook this condition and important to recognize it, because if you don't, it can progress to sort of organ damage quite quickly, and it is treatable. Not necessarily curable, but treatable anyway. So he's anemic, he's got normocytic anemia, normal MCV, white cells and platelets normal, and they want to know what the most likely diagnosis is. Well, you need more information. You can't tell me on the basis of what I've given you so far. So blood film shows rouleau and increased background staining. And again, that's another of those sets of words that's worth learning about. Rouleau is red cells stacked up in lines, and background staining is sort of a blue film. But what both of those things add up to there being a lot of protein in the serum. It's the high protein content, the high globulin content that makes and particularly globulin protein, makes the red cells stack up and causes the background staining. That's what the blueness is on the stain. So we think he might have high globulins, but and again, high globulins could be clonal, they could be monoclonal, they could be polyclonal. So if he had some kind of inflammatory condition, he could have a polyclonal response. Maybe he's got an inflammatory arthropathy, that's why he's got bad back pain. Or there could be a monoclonal gamma globulinemia, suggestive of a clonal plasma cell disorder. Does that make sense? The polyclonal antibodies response, normal response to inflammatory process or infection, whereas the monoclonal is an abnormal production of multiple copies of a single type of antibody protein, reflecting the clonal nature of the plasma cells in the marrow. There's more information, and it is there's a large monoclonal band with immune paresis, so the normal immunoglobulins are suppressed. So at this point, you probably should have an idea of what the diagnosis is. Yeah, good question. There's MGUS, monoclonal gammopathy of undetermined significance, which is common in the elderly people, and it's not exactly normal. That is a clonal condition, but it's one that doesn't always progress, doesn't need treating, sometimes progresses to myeloma. So that's a low-level paraprotein that is usually asymptomatic, and may progress to myeloma, but may not. But then you tend not to have a monoclonal band that's normal, but you do sometimes get oligoclonal bands. So like you get several small bands in older people. So you've got, yeah, which we tend to say that's oligoclonal bands rather than an MGUS. But it's probably not a very different situation. Yeah. We don't see that as a pre-myeloma condition, but it must be due to multiple small clones in the marrow of different plasma cells. I don't know if that answers your questions. It's quite common to see oligoclonal small bands, so multiple small bands, each of which is clonal, and that's kind of considered a normal feature of aging, I guess. But then there's monoclonal gammopathy of undetermined significance, which is usually a single band, sometimes two. And then there's myeloma, which is the malignancy, full-blown malignancy. So it's a large band, so it's probably not MGUS. And it's got immune paresis, which is not normal with MGUS. Also, MGUS doesn't give you anemia. And there's a bit more information that he's got bad kidneys. And he could have bad kidneys because of his NSAIDs or some other disease, but it's all adding up. Back pain, normocytic anemia, monoclonal band, renal disease, renal impairment. It should be big. And the other thing he could have would be hypercalcemia, I guess, or a bone fracture. So it's all kind of beginning to add up for me, at least, to make me think of a malignant gammopathy, i.e. multiple myeloma. I mean, the hemoglobin and MCV would fit with anemia of chronic disease, but it doesn't, the other stuff doesn't. MGUS, I think the band's too big. He's got immune paresis, and MGUS doesn't cause renal impairment or anemia. Hodgkin's disease, why would it be, I don't know, why would we be thinking of Hodgkin's disease? I guess it could cause back pain and anemia, and maybe, but not the rest of it. CLL, we've got white cell count is normal. I haven't given you the lymphocyte count, but I'll tell you it's normal. Why would it be B12 deficiency? It's not macrocytic. Myelodysplasia doesn't explain all the features. Causes anemia, usually macrocytic anemia. Folic acid deficiency, again, usually macrocytic anemia. So of those, the most likely has got to be myeloma, I think. And the other thing that they might tell you is there might be the odd plasma cell in the peripheral blood. You don't necessarily see plasma cells in the peripheral blood, and even if you do, sometimes that can be a reactive change, but the plasma cell is the malignant cell that's producing the monoclonal band, and if you see lots in the peripheral blood in that context, that pretty much is convincing evidence of myeloma, although in practice we would do a bone marrow. And yeah, I've said it a couple of times, and I'll say it one more time. Anemia in myeloma is usually normocytic, but can be macrocytic, so don't be put off if you see that. Just like, yeah, alcohol normally causes macrocytic anemia, but there are some situations where it does something different. So nearly there. I think this might be, we've still got time, I think. I'm impressed. Most of you, I think you're all still awake. It's impressive because it's over an hour already. Okay, Mr. J, age 22, 6-week history of tiredness, nosebleeds, bruising, mouth ulcers, got a temperature, he's pale, bruises and mouth ulcers. So, I mean, tiredness, nosebleed, tiredness, bleeding, infections, you're thinking marrow failure if it's a hematology situation. And he has got pancytopenia and a completely inadequate reticulocyte response. So there is something wrong with his bone marrow. At this stage, I can't tell you for sure that it's not a vitamin deficiency. I don't know whether it's an infiltration or whether it's just marrow failure. And again, we've got the causes of normochromic normocytic anemia. Unlikely to be acute blood loss, doesn't explain the white cells and platelets. Chronic disease doesn't explain the white cells, platelets. Marrow infiltration or failure would explain stuff. Hemolysis, not on its own, that would only explain anemia. Iron deficiency doesn't give white cell and platelet problems. B12 does, but it's normocytic anemia, not macrocytic. Myeloma is possible as an infiltration. And I think some sort of marrow failure. And I think in that situation, most likely I would think aplastic anemia, but that's not. Just his age, the duration, it's unlikely to be an acute leukemia because it usually presents a bit quicker than that. But on the information I've given you, that's pretty much what I can tell you. It's going to be one or other of those. Assuming there's not any drugs that cause marrow failure. So what about hemolytic anemia? Because the microcytic, macrocytic, normocytic, where does hemolytic anemia fit in? Mostly it's a normocytic anemia, but if you get a really strong reticulocyte count, it can be macrocytic. And the classic clinical features, if you get anemia, jaundice, splenomegaly, you've got to be thinking about hemolysis. It's not the only causes, I mean, bad liver disease, I guess, but you've got to be thinking about it. And again, I said it several times, but I think repetition sometimes helps. MCV is a mean, it's an average measurement. So hemolysis can present with a normal MCV because you've got some small cells and some big cells. And there should, if you've got hemolysis, there should be a high reticulocyte count because the marrow should be responding to the red cell breakdown. And if it isn't, there's got to be some reason like folate deficiency or some associated disease that's affecting the marrow function. The other causes of high retic count is bleeding and recovery from a marrow insult like chemotherapy. If you give chemotherapy, suppress the marrow, marrow recovers, you'll get a high retic count. So all of these things are all just pointers to thinking about hemolysis, anemia, jaundice, that triad, think about it. MCV could be normal or high. Retic count will be high in hemolysis, amongst other things. But then you've also got all these other things. You'll have bilirubin from hemoglobin breakdown, high LDH released from broken red cells, low haptoglobin, because that mops up the hemoglobin and gets removed. If there's hemolysis intravascularly in the blood vessels, then you'll get hemoglobin released into the plasma, and some of that will leak out through the kidneys. I don't know, the textbooks often make quite a lot about that, but intravascular versus extravascular hemolysis. But in practice, there's often a mixture of both, so it's not all that helpful, except to say there is hemolysis going on. And then the thing about hemolytic anemias is the blood film really, it often gives you the answer. It can often give you the diagnosis, because there are some characteristic pictures that we see. So clinically, you've got the clinical features, you've got those general laboratory features, the retic count, the hemolysis screen, makes you think it might be hemolysis, and then what sort of hemolysis is it? And the morphology of the red cells is what tells you what's going on. So this is Mr. K, age 30. He's got splenomegaly anemia, a bit of jaundice. And on his blood film, most of the red cells are spherocytic. They've lost the central pallor. Instead of being extra pale, they're too red, too much redness, and too often small and round. And the other information I'm giving you is the direct Coombs test is negative. Dig back to what was the Coombs test, tell me. I'll give you a picture in a minute. And then the question that goes with that one, and I think this was a practice, either a practice or a real question. So an inherited abnormality of which of the following best explains these findings? Is it G6PD deficiency, which is the enzyme that you need to make NADPH, which protects you from protects your red cells from oxidative stress? And it's X-linked, common in the Mediterranean, and fava beans are an oxidative stress, so it's often Mediterranean people eating fava beans. Could it be a membrane cytoskeletal protein causing hereditary spherocytosis? Maybe, he's got lots of spherocytes. Is it an alpha globin chain problem like alpha thalassemia? Not really, because we've already seen thalassemia train, it doesn't sound like that. Is it a heme problem like a porphyria? That's not really what porphyria presents like. Is it a beta globin chain problem? Is it beta thalassemia? Again, no, it doesn't look like thalassemia. It's not presenting that way. It's presenting with spherocytes. So that's spherocytic hemolysis. So those small, completely dark red cells are spherocytes. And there's lots of them, and there's really only two conditions that cause that. One is hereditary spherocytosis, and there are a number of different membrane proteins that cause that. And they cause, my understanding is they cause the red cells to have bits of red cell membrane taken out of them by the spleen as they go through. And they end up being spherical because they lose more membrane than contents. And the only way to be when you lose, if you're a biconcave disc and you lose membrane but not contents, is to become a sphere. So that's why they look dark when squashed onto the blood film. So there's two things, hereditary spherocytosis, or autoimmune hemolytic anemia, and the difference between the two really is the direct Coombs test, because the direct Coombs test tells you whether there's antibodies stuck on the red cells. So the purple antibody stuck on the red cells is what's happening in the patient, and then the yellow antibody is what we do in the lab. So you add the yellow antibody, which is directed against either IgG or complement, and it will then bring together the red cells that have got antibodies stuck on them. So you see an agglutination in the laboratory. So people get very confused about direct Coombs test, but that's all it is. It's basically detecting antibodies on red cells, or if the antibody is an IgM, and if the pathological antibody is an IgM antibody, that sometimes falls off and leaves complement C3d on the surface of the cell. And if it's not there are, you can get autoimmune hemolytic anemias that are so brisk that all the red cells that have got antibody on them have been destroyed, so you don't actually pick it up. But most of the time, if it's an immune hemolytic anemia, you will have a positive direct Coombs test. So in exams, they're not going to give you a DCT negative autoimmune hemolytic anemia. That would be very mean. If it's in your exam, if it's an immune hemolytic anemia, they'll say the DCT is positive. So I hope that makes sense. So if it's spherocytic hemolytic anemia, it's either hereditary spherocytosis. In practice, is mostly a non-event. There are occasionally people who are sufficiently symptomatic that they need, say, have splenectomies, which improves the hemoglobin. They are at risk of gallstones, pigment gallstones. But most of the time, it's a bit of a non-event, or warm autoimmune. It can be quite a brisk hemolysis and quite a severe acute presentation. And I don't want to go into sort of all the details of each, because we're basically just doing blood count interpretations here. So I think he's got HS because he's got spherocytic hemolysis with a negative Coombs. So I think it's the membrane cytoskeletal protein problem. And actually, if you didn't even know about HS and you knew about the other things, you could probably have worked that out. Sickle cell, I'm just going to show you some pictures now, because if the blood film shows, if you've got hemolysis and you've got this blood film with sickle cells, these long, sometimes they're sickle, sometimes they're more sort of boat-shaped, I don't know. These long cells here, all of these, they're all sickle cells. And in sickle cell, you often get, by the time people are adults, they've often, because it's not only a hemolytic condition, but it's also there are vaso-occlusive events. So often the spleen gets infarcted so badly that it doesn't function by the time people are adults. So you often see hyposplenic changes as well. And we said target cells are a feature of hyposplenism, and I don't know if you can see this. I think that's a Howell Jolly body there. It's a very, very small remnant of red cell nucleus, and if you've got a functioning spleen, the spleen will take that out. So you don't normally see that in the peripheral blood, but if there are Howell Jolly body red cells with Howell Jolly bodies in going around, it makes you think hyposplenism, splenectomy. In this case, it isn't a splenectomy, it's a non-functioning spleen. So oxidative hemolysis, I talked briefly about G6PD earlier. And the classic features to some extent have to be learned. This is a result of oxidative hemolysis, and I think what's happened is that there's oxidative damage to the hemoglobin, and then the hemoglobin deposits, and then the spleen takes bits out of the cell, but you end up with these bite cells that have got little chunks taken out of them, or blister cells where there's like a pale area at one end of the red cell. And if we stained it with a supravital stain, we'd see what we call Heinz bodies, which are that's the little insert at the bottom right. And that's just staining those lumps of oxidated hemoglobin. It's one of the complications of sickle cell disease. So sickle cell disease causes, it's a chronic hemolytic condition, but the main complications are due to vaso-occlusive crises. So the sickle hemoglobin, the mutated hemoglobin, tends to sort of line up, and they call them tectoids, and it kind of stretches the red cells into those sickle cell shapes, and they're really rigid. They don't deform as they go through the small blood vessels. So you get repeated episodes of hypoxic damage to various organs. It could be bone crises, which is really, really painful. It could be spleen, it could be liver, it could be brain, it could be chest, lungs. It could be pretty much anything, skin. So there's repeated episodes of hypoxic damage, and what's happening with the spleen is there's been so many of them that the spleen is just dead, non-functional. Does it matter? It matters to the patient. It's not it's because you need the spleen to help you fight encapsulated bacteria. So pneumococcus, haemophilus, meningococcus, also malaria, and there's a dog bite thing, capnocytophagia. So you can get overwhelming infections, particularly due to encapsulated bacteria, if you don't have a functioning spleen. So they should, people who don't have a functioning spleen or or for other reasons have had their spleen removed, they should have vaccinations against those organisms. Does that make sense? So I'm not suggesting you take spleens out in people with sickle cell. I'm just saying hyposplenism on the blood film could be due to repeated infarcts in sickle cell, or it could be somebody who's had their spleen out for some other reason. Does that make sense? Clarify it a bit? Yeah, yeah. We are very, very close to the end, I think, now. We're nearly to the end of anemias anyway. And so, and I haven't told you every single anemia, but I'm hoping I've given you a perspective on the likely things you could get asked. So this is an 80-year-old lady who we already know has breast cancer, and we already know it's metastatic. She's bruising. And this is not just anemia, is it? Because she's got normocytic anemia. The bone marrow is not responding, sorry. It's got a high retic count. It is responding. She's got quite a low platelet count, and we've also got some clotting results now. This is slightly in anticipation of next week's lecture. So we've got, but you can see they're abnormal because I have given you the reference ranges. So the prothrombin time, which is here expressed as an INR, is high. The APTT is high, and the fibrinogen is low. So there's problems all through the coagulation cascade. And there's thrombocytopenia. And the question is, which of these is the most likely diagnosis? So in the interest of time, I might answer my own question. I mean, the blood count, you can't say that, well, it's not aplastic anemia, is it? Because there's a reticulocyte response. If there was aplastic anemia, the problem is in the marrow. It can't make red cells. So we know it's not aplastic anemia. Then cross that one off. DIC, well, that is possible, isn't it? Because that causes, DIC happens with cancer, disseminated cancer. DIC causes hemolysis, giving you anemia. It also causes consumption of platelets and coagulation factors. So that's a possibility. Essential thrombocythemia, so that's another of those myeloproliferative disorders. Gives you high platelet count, so I don't think it's that. Hemophilia A. Hemophilia A, as you all know, is factor 8, inherited factor 8 deficiency. We might talk more about that next week. But that gives you a long APTT, but it doesn't do anything to your fibrinogen, your INR, or your platelets. Or I guess you could, if you had a really big bleed, you could get anemic. But, doesn't explain what we've got. ITP is isolated it presents as isolated thrombocytopenia, and it doesn't cause clotting abnormalities. Inherited thrombophilia, i.e. Inherited defects that put you at risk of venous thrombosis. I don't think that's the problem, because that usually presents as venous thrombosis, not like this. No, I can't make it inherited thrombophilia in any way, shape, or form. Vitamin K deficiency gives you a long prothrombin time, or INR, doesn't it? Mostly. If you get really bad, vitamin K you need for factors 2, 7, 9, and 10. So if you had it really bad, you could have a long APTT as well, but primarily it's prothrombin time that gets long. Von Willebrand's disease gives you low factor 8. So you'd get a long APTT, but the rest would be normal. Warfarin overdose, like warfarin works through vitamin K, doesn't it? Works by preventing the regeneration of active vitamin K. So it's going to give you the same effect as vitamin K deficiency. Acquired hemophilia, well, inherited hemophilia didn't give you this picture, so acquired isn't either. So there's only really one candidate here as far as I'm concerned, which is the DIC. You might get more information. If you did have DIC, you'd get this, what we sometimes refer to as microangiopathic hemolysis on the blood film. So you get some spherocytes, you get some fragmented red cells. That's the characteristic feature of microangiopathic hemolysis. These very irregular things. There's some microspherocytes. There's all these fragments all over the place, loads and loads and loads of them. That's not normal. And you also might get some big blue cells. The blueness is a bit subtle in this picture, but that is a big blue cell, which is a polychromatic cell. And if you, because it's because of the hemolysis over a I mean, I don't know if we actually know exactly what happens, but I kind of assume that what's happening is you're getting microthrombi in small vessels. The red cells are then passing over these kind of blocked or partially blocked vessels and are getting broken up and damaged, and then the spleen takes bits out of the damaged red cells. I'm presuming that's what happens. I can't honestly tell you for sure. Yeah, you can have acute DIC, which is ours, like if you've got an E. coli septicemia or major trauma, or, you know, obstetric problem, then that would be an acute DIC, which would progress over hours. In cancer, it can be chronic. It can go on for months and months. You know, it can be chronic and it can be compensated. So, yeah, I don't know. I always assume it's damaged red cells passing over fibrin clots and blood vessels as a result of the DIC causing excessive thrombosis within the blood vessels, and then consumption of the platelets and consumption of the coagulation factors, and then damage to the red cells as they pass over. I mean, that's the only way I can conceptualize it, but I don't know if anyone can tell you exactly how that happens. But you do get spherocytes and polychromasia. And polychromasia is a reflection of the bone marrow. It's just the same significance as reticulocytes. In fact, if you stained it, you probably would, the polychromatic cell would probably be a reticulocyte, but it's blue because there's a lot of RNA in there. It's a young red cell, but not young enough to have a nucleus in it. And it signifies that the bone marrow is working hard to compensate for anemia of some sort. So DIC is not the only cause of this picture. There are others, TTP, HUS, but it is one of the causes. And if you get lots of red cell fragments in that setting, where in something that you know causes DIC, then, and you've got all the features, thrombocytopenia, the abnormal clotting, I think that is by far, of those choices, that's by far the most likely. So we're all feeling tired, but I do have just a short, it's just one case about thrombocytopenia, because I think you can could do a whole lecture on thrombocytopenia, but there's an isolated thrombocytopenia is probably the thing you're most likely, well, it's the thing you'll come across that we won't talk about in other settings, if you like. And this is a very classic presentation for this condition. So a young child, 3-year-old, has had a recent viral infection. Sometimes it's a vaccination, and I don't know how relevant this is, because lots of young children have just had vaccinations or viral infections, but often that is apparent in these people, and it's a recent onset of bruising. She's been fine up until a week ago. So she hasn't been bruising since she's been born. It's not an inherited problem, it's a recent thing. And she's not on any medication, and she's got a normal hemoglobin, normal MCV, so she's not anemic, normal white cells, but her platelets are really, really low at 3. So I mean, the first thing to do is to repeat the blood film, because it could be that it's been a really difficult venipuncture and the blood sample's clotted, and the lab possibly haven't noticed that there's a clot in the sample. They should do, but they might not have done. And all the platelets are in the clot and left in the tube. That's possible. So it does need repeating, but if it's repeated and it's the same, there's really only one thing that causes that, like an acquired severe isolated thrombocytopenia in someone that's not on medication. Is that fair? I think that's fair, really. I mean, the things that cause isolated thrombocytopenia: medication, alcohol, viruses, and ITP, splenomegaly. It's true, yes, splenomegaly, but she hasn't got splenomegaly, and autoimmune, by which I mean idiopathic thrombocytopenic purpura. So I'm thinking this is ITP until proven otherwise. There are rare inherited severe thrombocytopenias, some associated with skeletal malformations and other things, but that's not her problem because this is recent. If there was splenomegaly, then you should doubt the diagnosis of ITP, because ITP is not associated with splenomegaly. And that's one of those, I don't know, something I've found useful in practice, having that thing in my head. If it's isolated thrombocytopenia and there is splenomegaly, it's not ITP. And in adults, it might be liver disease with portal hypertension due to cirrhosis or something, or it's lymphoma or something else. But it's not just ITP if the spleen is big. Just one of those things to carry in your head that is quite useful from time to time. So the blood film just showed severe thrombocytopenia. It would be really, I mean, small children do get acute leukemia. They get ALL more often than AML, but acute leukemia doesn't really, it could present as a pancytopenia, but it doesn't really present as an isolated severe thrombocytopenia. It would be very, very unusual presentation. Similarly, things like myelodysplasia doesn't usually present like that, and it's vanishingly rare in small children. I think you've got to think about medication and ITP really with that picture. So I have finished a little bit early. I can take any more questions if there are any. I hope I've covered the most important anemias and also some general principles that will help you approach your exam with confidence, and also be good practicing doctors. Yeah, don't panic. Just